because otherwise we're not going to have enough time to get through this. So why don't we just, the panelists can come up and I'll introduce you as we get started. Yeah. Sit however you want, there's no order. Yeah, we have a few famous ones in the house. Who knows? I would put it under your chair.
We have to mix it up. We just can't have the three black guys.
Yeah, I think so.
We gotta go. You know.
And a lady. We need a lady.
The uptake is not good.
We need a lady.
No, you should.
Okay.
Oh, Shola's organizing this. I guess you need to.
And then I'll cover this end. Yeah, it looks better this way.
I love when there's so many bosses in the house. I'm wondering if I can you get somebody to shut that door back there? Right. And do we only have this? There's one here. Okay, good. So something's organized well. Welcome. Hopefully more people will trickle in, but we wanted to get started. This is the session titled, Is Household Air Pollution Even More Harmful Than We Thought? Emerging Evidence on Health Impacts of Household Air Pollution. So if you're not interested in the health impacts of household air pollution, you're in the wrong spot, but hopefully everybody here is. So no, my name is Donnie Alexander, and I'm the Chief Science and Learning Officer here at the Clean Cooking Alliance, and this is probably one of my greatest honors to sit on the stage with these people today, because really these are people who have been looking at all of the health impacts of household air pollution. We all hear the numbers, 3.2 million I think is the latest WHO number, deaths a year, premature deaths. But what does that mean when you start looking at it at a deeper level? And so for years, we've kind of understood the impacts on adult health, really, on the lungs and heart. But in more recent years, we've started to look at birth outcomes, and things like that. So we're going to get a little bit more into that and the role that clean cooking can play in that. So I want to take a second here to introduce our esteemed panel, because we have a wonderful panel here. First, to my left, we have Dr. Kwaku Poku Asante, or KP Asante. He is a medical doctor and an epidemiologist. He's the director of the Kantampo Health Research Center here in Ghana. And KP has one of the longest randomized controlled cooking trials, and now a cohort looking at the health impacts of transitioning or utilizing clean fuels in relation to those who don't. So he has had a study called the GRAPH study that so many of us in the field look at, because they've had such interesting data coming out on this cohort. So we're going to talk to KP a little bit today about some of the findings of that cohort that he has been doing in collaboration with Columbia University. Next up, we have Dr. Maggie Clark from Colorado State University. Maggie is an associate professor and an epidemiologist. Maggie has done a lot of research in Central America, in Honduras and Nicaragua, and is part of the famous, well, in our space, famous HAPPEN trial. And so, well, I think we'll get to hear a little bit about the HAPPEN trial, but also some of her work looking at technologies that are really, I think, quite specific for the context in Honduras, some advanced biomass stoves with chimneys and things like that, and what they're seeing in terms of health indicators there. After that, we have Dr. William Warodria. He's a senior consultant physician at Mulago Hospital in Uganda. And Dr. Wardry is a pulmonologist and has been one of the co-PIs working on a HAP COVID study. So we are looking at the interactions between household air pollution and COVID-19. And we'll talk more about his study that is looking really at, what does household air pollution do? How does that affect your recovery once you get COVID-19? Next, we have Heather Rouhani. She has been, is the acting unit head on air quality and health at the World Health Organization. Heather has been at WHO since 2010 and has really been working with country governments to work on the topic of passing standards and air quality guidelines in their countries. So she works a lot with policymakers, but also has been really active in the ISO cookstove standards, WHO has. And so we'll talk a little bit more about what that means in this panel. So with that, I think I'll get us started. Oh no, I gotta introduce Shola. But last but not least, Shola was my advisor at the University of Chicago, and I think really taught me most everything I know about looking at household air pollution. Shola is a pulmonologist, and he is the Dean of Academic Affairs for the Biological and Sciences Division at University of Chicago. He has a randomized control trial in Nigeria looking at ethanol, so an ethanol intervention. So a different kind of clean fuel than what we've been talking about. And they have, I think at this point, 9 or 10 papers that have come out of that on those health impacts. And so I think we'll talk a little bit about that. But also, Shola now has a big study looking at cognitive impacts. So he's following those same children. And so we'll hear a little bit from that. And I think that's going to be really unique today when we talk about that. Sorry, Shola, your name was first on here, so when I got down to Heather, I skipped you. So let's get us started. And I actually am going to start with Shola on this question. I would love to hear, so Shola, you started a randomized control trial looking at the impacts on maternal and child health in Ibadan, Nigeria, using ethanol, which is a clean fuel. I would love to hear a little bit about what that trial consisted of and some of the results the findings that you had from that trial.
Can you hear me? Yeah, thanks for having me, Donnie. It's nice to be here and to see so many friends and interest across the area beyond healthcare. The randomized control study that we did in Nigeria was triggered by, work that I was doing as a pulmonologist that had nothing to do with indoor exposure. It was a study to look at whether early exposure to dirt in life has anything to do to our immune system. So we were inside some of these homes collecting dust samples, and lo and behold, the walls were just black, So I went from thinking about, asthma and hygiene hypothesis to going back to look at a cohort of families with about 60 households with a woman and a child. Went and looked at exposure levels during cooking. And I was alarmed because I didn't know much about household exposure. This was about 15 years ago. And when we were looking at PM 2.5 and PM 10 levels at that time, they were like 100 times, WHO standard, 1 hour into cooking indoors. Because we couldn't and then that was the beginning of the rocket stove. We tried the rocket stove to see whether we could improve the indoor air quality. Indoor air quality was improved, but the moderate to severe obstruction, a pulmonologist, obstructive defect that we saw in both the mothers and children didn't improve. So I thought the next thing to do was to see whether we could look at a pregnant cohort. I have a health policy background, so in a lot of the low-income countries, people don't really care about electricity and things like that. But when it comes to women and their children, people cared. So that was actually the genesis of trying to do the randomized control intervention in that pregnant cohort. What we did effectively was looked at women who were cooking with kerosene and firewood, and we randomized them into two groups. The intervention was ethanol, which most rich people cook with on their boats. I'm thankful to the Alliance at that time gave us some money, but didn't know how much ethanol or stove cost, but we were able to actually do it. We were interested in knowing whether transitioning people from from kerosene or firewood to ethanol would improve birth outcome, whether it would reduce exposure. And what we did was we used the micropam, which is gold standard at that time. We also introduced GPS because we were interested in quantifying indoor versus outdoor exposure. We used ultrasound 6 times during the pregnancy to look at intrauterine growth. And of course, we did a lot of biomarker stuff. And at the end of it, the findings were as follow. Most of the exposure, 70% of the exposure was indoors, meaning that 30% of the ambient exposure, there was really nothing we could do about it. The second thing was that the intervention group, the ethanol, they were able to carry their pregnancy to term in a more significant way than the blended control group. The babies were also about 80 to 90 grams bigger, which really wasn't significant, and it's not different from some of the other studies that I've looked at birth weight. But we actually noticed there were more miscarriages, more stillbirths in the blended control group, and that the intervention, without really doing any other thing, reduced the risk of hypertension in the pregnant cohort that we studied at that time. And in fact, the diastolic blood pressure was significantly lower in the intervention group, even though everybody started at the same level. The reduction in exposure was very, very minimal, not significant to drive some of these changes if we really want to look at reducing exposure level. And the way we looked at it was the ambient exposure level was really too high for the intervention alone to do that. Midway through the study, what we thought we would do was also collect cord blood and also the placenta in these pregnant women to see whether we could see evidence of adverse effect in the placenta. And lo and behold, when we looked at the placenta, you could see that the women who were in the control group, meaning firewood and kerosene, we could see histologic evidence of hypoxia in the placenta. And for those who, and the biomarker evidence of hypoxia because the HEAF expression level was also high. And for those, to put it in context for non-scientists here, if you go to altitude, you know the oxygen level is low. The way the body compensates is you produce hypoxia-inducing factor that gets your blood, your body to produce more hemoglobin. So by looking at the histology, seeing hypoxia and evidence of that the babies grew up in low hypoxia setting is a setup for the cognitive development work that we're doing. But the most important message that I'm hoping I will get across today is actually beyond the science. What did the women think about this study? Because after the study, they wanted to adopt this stove. Number one, the clean cook stove made them as if they were in a higher socioeconomic group because it's stainless steel stove. Number two, they didn't have to replace their stoves like they would ordinarily do every 2 years because this stove can last for 8 to 10 years. Number three, their pots and pans were not black. Number four, the exposure-related complaints were minimal. Number 5, they could cook with their children next to them. And that was why they wanted this stove. It had nothing to do with any of the stuff we were interested in. And I say that because I know that there are non-scientists here. It's all about behavior change as we think about how to get people to adopt all of these stoves. I think I'll stop there.
Yeah, and
In summary, that's pretty much what we found on that study.
he found a lot, is what he's trying to say. A lot of really interesting health impacts came out of that. And what was really interesting in this study, I think, was that Nigeria had, at the time, a very high kerosene use in homes, which is not always the case. Oftentimes it's charcoal, and kerosene is really, really dirty stuff. And I think the other thing was this was in an urban setting, in kind of the slums of Ibadan. And so there was tons of ambient air pollution everywhere, but with the study, they were still able to see some health impacts come out of that, despite being in a really dirty city. I want to ask you, Shola, if you were to look at this again, in addition to this, trying to reduce air pollution in the home, would there be any other things that you would look at and add to that in terms of just a cook stove, or to really reduce that air pollution?
I mean, if I were to do it differently, it would have been nice to have a place where the ambient exposure was not as high. As always, it's always nice to have a larger cohort, which I'm happy the Happin study was able to do, get a larger cohort to look at things that are similar to what we were interested in. And I was actually very disappointed, even though I was prodding them to actually get as much placenta as they could, because to me, that's actually the biggest challenge, because if exposure during pregnancy can lead to hypoxia in the placenta, it has implications for cognitive development of the children. It would have been really much more powerful beyond the birth weight outcome. And then having a cohort that we can follow for a longer period of time. I mean, we did other things in terms of trying to look at childhood development of obstructive lung disease. We've looked at the impact of self-determined stress by the mothers in terms of whether that had any other thing to do with pregnancy outcome. It's a very complicated issue when we're looking at it from the scientist, biologic science approach, because I think what I've learned is that a lot of the social and behavior change issues are just as important as all of the other biological markers that we often focus on as scientists.
Yeah, thank you. And KP, you have an even bigger randomized controlled trial here in Ghana, and I think the children are now, 10 years old? And some of the data came out in the beginning after the birth outcomes were not in line with what Shola had found. But then at 4 years, from what I understand, you are seeing some differences in the groups between the control and the LPG. Can you describe your study a little bit for the audience, but then talk about the results that you've seen in your study?
Right. Thank you very much, and let me welcome you all to Ghana. So our study was based in the Kintampo area, and that is in the middle part of Ghana. We're now in the southern part. Unlike Shola's, that area is a largely rural area with probably little ambient air pollution from vehicles and others like that. And it's also largely poor, rural folks that live there. About 15 years ago, we noticed that about 80% of households use biomass fuel, and it was mainly just firewood. And so we spent about a year looking for a clean cook stove. We tested various cook stoves. Eventually, just as we were about to decide on a few, we realized that a company has set up an LPG tank. That meant that it was so close to us that we could easily use that facility to deliver our intervention. And so we decided to select 2 interventions: an improved cook stove that still used firewood, and then an LPG. and the LPG was supplied free of charge, and this is important for the discussion, for almost 2 years of their participation in the trial. And what did we do? We recruited pregnant women from earlier on in their pregnancy. We delivered a cook stove to them and also delivered a BioLite to them and compared it with those that use their traditional firewood. In total, we had about 1,400 pregnant women involved in this trial. And when we delivered the intervention, we followed them up right through pregnancy until the first year of life. What were we interested in? We're interested in looking at the impact of the intervention on birth weight, for one, and then two, interested in looking at the impact of the intervention on pneumonia in general and also on severe pneumonia. Severe pneumonia is the type that will usually get children into the hospital, and if something is not done, they'll lose their lives. In addition, we measured their exposure to carbon monoxide and particulate matter at various time points during their involvement in the trial. When we delivered the intervention to the participant, we realized that use of the LPG stoves was very high, and the motivation for use was similar to what Sola has just described: fast, easy to use, and all that. We also gave the BioLite, and we repaired the BioLite. So all the intervention was at no cost to them. And what did we find? At the end of the day, we found out that the pregnant women that were exposed to high levels of exposure had their children's birth weight reduced by about 50 grams. That means that if women are exposed to about 1 part per millimeter of carbon monoxide, their children's birth weight is likely to be reduced by 50 grams. And this is important because it's crucial for a child to have a birth weight of about 2.5 kilograms at birth so that their growth can be improved. In terms of pneumonia, and let me just say that at the time, the use of vaccines against pneumonia was very low. It wasn't existent. Now it's available. And we realized that children that were exposed to carbon monoxide and particulate matter were associated with a higher risk of pneumonia and actually a higher risk of severe pneumonia. So this is what we found during birth and also 1 year after birth. We have continuously followed up the children. As was said earlier on, the children are about 10 years old now. But as we speak, we had done an analysis of the blood pressure measurements we did when the children was 4 years of age. And we noticed that children that had been exposed to household air pollution intrauterine or during pregnancy had higher blood pressure measurements at age 4. And again, this is also important because children that have high blood pressure at that age are set up to have higher blood pressure when they grow. Similarly, children that have had their lung functions not as appropriate as normal, as we found in our study at age, also during the trial, we realized that children had poor respiratory outcomes. That means that their lungs were not very developed if they were associated with high exposure to carbon monoxide. Again, that sets the children up for poor respiratory outcomes later on in life. So these were 3 key things that we found in our study at birth and then also at age 4.
Thank you. And can you clarify something, because I think it's really important, at least as I understand it, the free fuel was only given out for 2 years. So did most people go back to traditional cooking? And does that potentially mean that that early intervention is really like lasting despite transitioning? Or can you talk about a little bit about that relationship?
Well, thank you. So we gave the women free fuels and actually repaired the stoves anytime they were spoiled. And then we stopped when the children were 1 year old. When we did, some of them regressed back to their traditional fuels, although they kept the canisters or the cylinders, and at times they would refill it. But it wasn't as maximum as we did. So it's important to, if we want to target any health impact on health outcomes, we probably would want to do it during pregnancy and early on in life. It's important to note that if they can't afford LPG, it's unlikely that they will have it if it's not freely available.
Thank you. That's really interesting. And Maggie, you've done a lot of work in Honduras and other places, but I want to talk about the HAPPEN trial. And for those of you who are not aware, the HAPPEN trial is a large, multi-country trial looking at birth outcomes specifically. And so I would love to hear, I know from the trial that you've seen really high uptake of LPG and significant reductions in air pollution. Can you talk a little bit about where the trial is located, the number of participants you have, and what some of your findings on the health side are coming out to be, and how do we interpret that?
Thanks, Donnie. So speaking on behalf of the many, many investigators that were involved in the HAPPEN trial, the goal of our study was to actually find, as Shola was suggesting, areas around the world where we did not anticipate that there would be higher levels of ambient air pollution. So we wanted to sort of isolate communities in places where we thought their biggest contribution to their personal exposures to air pollution would be from their cooking. And so that said, we recruited participants in very rural areas of Peru, Guatemala, Rwanda, and India. We recruited 800 women in each of those 4 locations, and the recruitment criteria was that the women were between 9 and 20 weeks gestation during their pregnancy. We were very pleased with, well, actually, let me take a step back. So the intervention was an LPG stove and fuel intervention in a very controlled situation. So this was intentionally a proof of principle study where we knew we weren't being very real world, so to speak, but where we thought scientifically we could try to isolate the impact of cooking in a way that could help inform real world situations. And so the LPG stoves and fuel were provided free of charge. We had very intensive behavior change campaigns. I believe there was 2 years of formative research in each of the locations to try to understand what the behavior change would look like. So that sort of set up the study. And then we have published our primary intervention exposure results, and we're very pleased to see that the PM 2.5 personal exposures were reduced to, I believe the median was right around 25 micrograms per meter cubed. And so this, we felt was a big win in our field, just trying to build upon the work that we had done previously, that our colleagues had done previously. And as Donnie mentioned, one of our primary outcomes was birth weight in the children. And so that paper has just been published in the New England Journal this week. And what we saw was that birth weight in the intervention group was reduced by about 20 grams. So if you remember what Shola and KP were saying, this is considerably smaller as far as a difference than what some previous studies had observed. However, although the results of the intention to treat were not statistically significant, that reduction was in the hypothesized direction. And we have not published the exposure response results yet. We're hoping to do that very soon. But what we were able to see was that black carbon personal exposures were associated with birth weight as well. So I guess I would say even though the absolute difference in grams in birth weight between the intervention arm and the control arm for HAPPEN across the 4 studies wasn't quite the magnitude that we were hoping to see, we do know that PM 2.5 and black carbon were greatly impacted by this intervention, and black carbon does seem to be a very important pollutant when it comes to influencing birth weight.
Thank you. That's really interesting. And so, Heather, working at the WHO, and the WHO takes all of these data and sets guidelines. And recently, was it maybe 6 months ago, the bar kind of moved on these guidelines for what is protective for health. And so I would love to hear you know, as practitioners, where we're talking about trying to get as low as we can and what is clean, can you talk a little bit about the guidelines and what is your, you know, kind of advice for us as we continue to go forward with these clean cooking programs from a health perspective?
Sure, and thank you so much for having me. I'm very excited to talk about guidelines and be on this panel with these very distinguished scientists. Thank you very much. So, first of all, you hear a lot WHO standards and WHO guidelines, but I want to just quickly tell you what those are, because you hear them, but I don't think a lot of people understand how much work goes behind these. These things take about 5 to 6 years, and we have basically gathered scientists from around the world. The ones that were recently published, it was actually, we released them in September 2021. Those took about 5 to 6 years, but they're really guided towards, well, it's meant for all environments, both indoor and outdoor, but it's really more guided for the ambient levels because the new guideline values are even lower, and they tell us for fine particulate matter that we really need to get even further. Basically, 5 micrograms per meter cubed is now the guideline value. Now, is that realistic at the moment for many of the communities where clean cooking is an issue? No, but that's why we provide the these interim targets. And so the interim targets were basically stepwise levels that countries can take and set their own standards as they progress to actually achieving the WHO guideline levels. Also held within these guidelines, we provide the guideline values for particulate matter, carbon monoxide are the most relevant for here, but we also have nitrous dioxide, sulfur dioxide, ozone. And we actually also, speaking of black carbon, we've had for the first time a good practice statement on black carbon. So there's a bit difference between what recommendations are and good practice statements. Recommendations are we have very, very strong evidence base on the health evidence base to say that yes, WHO agrees these are the values that one must achieve to protect health. The good practice recommendations are those that really are more where there's suggestive and strong suggestive evidence that this is something that we need to study more, and that we can make some kind of, not a recommendation, but a general statement to drive people to gather more evidence and to help us build that base so that we can provide the actual values of black carbon or values that one has to achieve. So it's really great to see that the research is showing, and we're getting more data on this black carbon and the importance of its exposures. And this really is something that I drive all the audience and all the researchers to do, is to gather more data on actual black carbon exposure, what levels they're having, and get some emissions inventories, et cetera. We also provide some guidance on ultrafine particles as well, where we're really finding that's important. That's another good practice recommendation, but we're really driving science to do as well. Now, how does this translate to household fuel combustion? This is where it gets a little complicated, because then we talk about guidelines and then other guidelines. Yep. So, these are the ambient air quality, like I was saying, well, they're not really ambient air quality guidelines, but they're guidelines that were launched in September 21. We also have other guidelines, the WHO guidelines for indoor air quality, household fuel combustion. And these are specifically designed for technical practitioners like you to help actually achieve these values that are produced in these other guidelines that were recently launched. So they actually look at specifically the technical recommendations on emission rate targets, what fuels and technologies are safe, where we have specific recommendations against unprocessed coal, kerosene, and also this idea where there's best practices, again, with this idea of combining both looking at climate mitigation and having that continue to accelerate actual household energy policy and progress as well. So inside of this, it's a lot of very complicated things, and this is where you actually want a PowerPoint so you can have the diagrams instead of me talking about guidelines. So these are very just important to let us know that we actually need to be pushing more and more for clean air to protect health. And it's not just to protect health, it also helps with climate mitigation, improves social welfare, et cetera. But the point is we need to go further and we need to push more and more for clean air, and clean cooking needs to do that. We know there's such an important contribution, as we've heard from all the scientists here and then earlier in presentations, that household air pollution is a massive contribution to outdoor air pollution. Yep. So if we really want to protect all air pollution, clean cooking is a massive way to do it. We know that in some places, in some states of India, I know studies have been shown that 50% of the outdoor air pollution is actually caused by the household air pollution leaking outdoors. So by us working on clean cooking and achieving these air quality guidelines, or at least striving to, we can really protect the health of people indoors and outdoors.
Yeah, thank you, Heather. And actually, CCA commissioned a study earlier this year, a review looking at that contribution from household to ambient. Also, the Health Effects Institute has a lot of data on it. But, you know, anywhere from, you know, 16 to 20% of ambient air pollution globally is coming from household air pollution. And as you said, in South Asia and other parts of the world, it can be much higher. So it is really important just to drive down those air pollution just in general. I want to go back to you, though, as we think about this, just get a little bit more about how do we think about this in terms of stoves and fuels and burning of stoves and fuels. Here at the Clean Cooking Alliance, along with many partners that I actually see in this room, we've been working on a cook stove standard through the ISO cook stove standard. So the International Standardization or Organization for Standardization has a cook stove standard. And it gives us levels of tiers for emissions for PM and CO, along with safety, durability, and efficiency. But the emissions is what we're really looking at when we think about health impacts. WHO was part of this process, so we could develop those standards in line with WHO. So when we talk about tiers, or the emissions tiers for PM and CO in line with WHO, what does that mean? What kind of stoves and fuels really get us there? And then, you know, if we're not there, what does that mean?
Thanks. No, this is important. This is one of the most practical ways, I think, it's actually how to translate those guidelines into something that countries can do, and we can drive the industry to achieve the clean and health that we need. So, as Gear said, WHO served as the Category A liaison in the ISO standards, and we've actually developed specific guidance to help actually make sure that the WHO guidelines have been integrated into these tiers. And we actually have, for example, guidance on countries to actually implement these and make sure that they're health-based targets if they want to set their own national targets. Now, sorry, I got a little lost. Okay. Yes, so the stove. So what we actually can achieve for clean, and that's basically what we count here for clean. We've seen by the evidence and from basic field and lab studies that we count clean as those fuels that are clean, considered LPG, natural gas, ethanol, biogas, and of course we ultimately want to choose renewable electricity. That's where we really want to get to. So this work on e-cooking is fantastic. But we recognize also that we don't want to be very neutral. We want to be fuel and technology agnostic. That's why we set these values. So we also approve and appreciate the importance of role of biomass, particularly as a transitional fuel, and we really want to push stove innovators and things to really get the lowest emissions possible. And we want to make them affordable, and we want to make them last a long time. So we really have these so there is the opportunity to get to the tier 5, tier 4 stoves. That's a way that we can actually count as transitional fuels and technology, because there is some health improvement, and that is an important step towards achieving clean. Because we know clean is not going to happen by flipping a light switch, right? We can go turn it on. No, that's not going to happen. It's going to progress, and it's going to take a lot of time for countries to do this. You got to set up the infrastructure. You got to establish the market. You got to deal with affordability issues. And these countries where this is a problem, this is a huge challenge in competing with so many other issues that they have to deal with regularly. So I really encourage you all to look for the information that we have in your communities of what we have about standards, and make sure that the health is incorporated in them, the guidance we have. This is all included in our Clean Household Energy Solutions Toolkit, which you can find on our website, which has many videos associated. We have information on standards development, but also things, a cost-benefit tool, interactive one you can use online, one that can also, we have things on survey questions, et cetera, so that we have a full policy manual to help you follow through.
Thanks, Heather. So, Dr. Worodria, I want to talk a little bit and transition a little bit now to COVID, because that has affected all of us over the last almost 2.5 years now. And when that first happened, we started to see some news articles and even some journal articles coming out about the potential interaction between air pollution and COVID-19, both outcomes and transmission, but all of that data and literature were really in ambient space. So, William, what CCA did during this time, because we weren't able to do programmatic stuff in the field, we actually diverted some of our funding to look at this issue, because it was something that we thought would be important to understand a little bit more about that interaction. And one of the studies that we funded was a study that Dr. Warodria is leading or co-leading in Uganda. And this study, I would love for you to talk a little bit about the study. What are you looking at? What are the outcomes that you're looking at? And what are the results that you have seen? I know they're preliminary, but what are the data telling you to this point, William?
Yeah, thank you for inviting me to participate in this meeting. We, with my colleague Peter Moscovich, did study the impact of air pollution on COVID-19. Rightly, you did say air pollution greatly impacts the manifestations of COVID, and it's best described as a syndemic because we have, on one side, an epidemic of non-communicable diseases, and on the other side, COVID-19 and other viral infectious diseases. So the literature out there agrees on the fact that air pollution, as you said, ambient, is associated with increased infection, and it also impairs the capacity of the body to respond to the virus. The resultant effect is increased transmission and hospitalization. What is not clear is whether air pollution affects the recovery following COVID-19. And that was the question we looked at in two cities in Uganda, Kampala and Mbarara. We enrolled 150 participants, 50 with mild COVID, 50 with moderate COVID, and 50 with severe COVID. And all of these had personal monitoring of exposure over a duration of 3 months. Every 6 days, we sent study staff to their homes to monitor these air exposures. And we also followed them, assessing their lung function during the period of the study. Overall, 92% of the people used biomass fuel, only 8% used LPG, and some used electricity, but those who use electricity also used biomass fuel. Yeah, and we did also observe a few things. This was a highly educated population because most of them had some kind of tertiary education. This was probably the capacity to appreciate the value of what this study stands for. And we found that most of the mild disease people, about 85% had been vaccinated, while those with severe disease, only about 30% had received vaccination. And the PM2.5 concentrations were about 55 micrograms per meter cubed, which is way above the WHO interim guidance that you have had. And during follow-up, we did notice that people who had high exposure of PM2.5 at onset had a less improvement in the lung function over the 3-month period. So in a brief way, we'll say that PM2 exposure probably impairs lung recovery post-COVID. And an observation we also saw was it seems it's good to be vaccinated. Thank you.
Yeah, thank you. That's really interesting. And I think it brings us to the question, if you have all of these insults from air pollution, and it's affecting your cardiovascular system, your pulmonary system, and then we have things like pandemics, right? It's just one more insult. So from your perspective, if you were to go back, William, and talk to the ministries of health or in your country, think about a policy, have a policy discussion on this in terms of protection of health, what would your message be about exposure to household air pollution and on this?
Clearly, it seems to emerge that clean air is certainly an important issue when it comes to recovery. though, as we say, the relationship is complex and there are multiple manifestations, facets of this. But I think taking it forward, adopting a clean energy approach and clean air would be facilitating this.
Yeah, thank you. Thank you. I want to get back to you, Shola, because we talked a little bit about your primary study, but you are now following that study, that study. You're now following those children as they grow, and you're looking at, as I understand it, some cognitive impairment and cognitive outcomes or in that. Can you discuss a little bit about what you're looking at and what you're measuring in the new cohort and how long you plan to be following this and what your hypothesis is in terms of, what you'll see in between the two groups?
Yeah, as I mentioned, we found evidence of hypoxia or low oxygen in the placenta. So we have that cohort of about 250 children that we've been tracking now for almost 8 years as the discovery cohort. So we have an implementation science approach to the ongoing work. And it's important for those of us who do RCT to know that when you start talking about implementation science, it's a different approach. We're interested in creating, and we're actually working with the Lagos state government in partnership, so there's a private-public partnership. We're trying to create an environment for entrepreneurs to come and make ethanol available to the households. We want entrepreneurs to come in and also start figuring out how to locally manufacture or put together the stoves. But from our standpoint, we've been doing needs assessment in about 35 communities in Lagos. Lagos is very big with a population of about 18 million people. So we're doing the needs assessment to talk to the people. We're introducing the stoves to them. This is a totally new cohort in an urban center. We're interested in willingness to pay, what it would take for these people to transition from what they were using to a new stove. Clearly, affordability is important. We're having discussions about smart subsidies. Because we also found that hypertension, kerosene was a major driver of hypertension in the pregnant cohort, and knowing that hypertension is a major cause of morbidity and mortality in Nigeria, we have on the back end, we are looking at about 322 households that may not adopt the stove, to see whether the intervention would actually have anything to do with the hypertension in the larger community. And our hope is that if we're able to get ethanol, the fuel, close to the people, to put it in context, gas now in Nigeria is about 850 naira. If you look at ethanol, it's about 300 naira. So there's really an opportunity, to be agnostic about, especially if you have a tier 4, tier 5 stove. So we're trying to take advantage of that opportunity, the cost differential, to ensure that, like the women in Ibadan, that the women in Lagos would also, based on seeing the stove, haven't seen the stove because it burns blue. They're more interested in it, but they're asking questions about, will it blow up? What are the burn risks? Which were some of the concerns that some of our women in Ibadan also had. So we're encouraged and see this as an opportunity to, let the research inform some of the changes and implementation down the road. And it's an opportunity to also bring private enterprise into the picture, because the government can't fund all of it, and clearly research can't fund all of this. But we are doing, just to step back a little bit, we're also actually enrolling a new validation. So the original cohort, we have that as the discovery cohort. So we are recruiting another 250 pregnant women and their children into a new cohort that will be the validation cohort. And then we have a community cohort, and then we have different instruments that we're going to be testing in these children as they grow up. And we are really excited because we'll do personal exposure monitoring. We'll put stove use monitoring in the stove so that we can know what they're using. And it's a nice continuation of the RCT and it brings meaning to this work every day.
Yeah, thank you. I can't wait to see some of the results of that, because really that's not, as far as I'm aware, not being done anywhere else. Perhaps in graphs you're looking a little bit at the cognitive impairment too. Are you, KP, are you guys looking at that as well?
Yeah, so it looks like Solar's group and ours are thinking together, and I think that's the beauty of research, right? So yes, we are interested in looking at neurodevelopment outcomes, also respiratory outcomes as the children grow, and then also cardiovascular outcomes, blood pressure as the children grow. We're also interested in following up all these children through adolescence, because immediately they get into adolescence, the hormones do change several things, and it will be important to study that as well. We have the opportunity to monitor other children in another large cohort. We have a study that has about 3,000 children and their mothers being enrolled, a birth cohort of about 3,000 children being enrolled into this study and funded by the Bill and Melinda Gates Foundation. So we also are planning to put in air quality monitors in some selected areas, and probably looking at how we can put in air quality monitors in their homes as well, and then to monitor impact over time. These things may change as we go along, because in our study, placental malaria was a huge modifier in terms of the impact of air pollution on birth weight. Placental malaria is reducing now, and so what else is contributing to that, and how do we measure it? These are the things that we intend to do in the future.
Mention that because when you think about cognitive development, there's so many factors that are involved. So we're really doing heavy metal screening in all of these children to look at lead, to look at cadmium, and all of those other things that could contribute. We're looking at nutritional biomarkers. We're looking at the intellect of the mothers or the caregivers in the case where the mothers are not the primary caregivers, so that we have really a holistic approach, not just focused on just the exposure, to look at other non-exposure related factors and the environment where the children are growing to have a broader, to give broader meaning to whatever we find.
It's definitely a complicated picture in these cases, and I think that's why the results are sometimes complicated or hard to understand. I don't want people to take away, and Heather talked about this too, that we want to get to as clean as possible, but a cook stove is one part of the house. There's other things that are happening, and in many places ethanol and LPG are just not feasible. One place where Maggie, you actually have done work is in Honduras in the past. And on Honduras, it's, you have a comal or, you make tortillas, and oftentimes the most appropriate stove might be a planchas type stove with a chimney or something like that is a biomass burning stove. And I know, Maggie, that you've done a lot of research on some of these subclinical indicators. Can you talk a little bit about those results briefly, and what your thoughts are in terms of, or your kind of contribution in terms of, if you can't get to clean, are you still seeing some benefits from some of these more transitional technologies that we've talked about?
Thanks for that question, Donnie. Yeah, so we conducted a stepped wedge trial in rural Honduras. So again, we were targeting an area where other sources of pollution were expected to be lower, where we thought the cooking technology was the primary source of the exposure for these families. And we really intentionally took a community engaged approach where we were working with our community partner, working with the local leaders and the families to try to understand what the preferred style of cooking was in this area. And so we worked with our partner Odessa and Trees, Water, and People on a stove called the Husta stove, which, as Donnie mentioned, is a plancha stove. It has a chimney and it has an improved combustion chamber. We had done some cross-sectional work where exposures among Husta stove users were relatively low. But what we wanted to understand better was if we took more of a community-engaged approach through the conduct of the research, could we actually see and observe lower exposures? So the course of this study, which was about 3 years, we observed that, of course, there was a distribution of personal exposure to PM 2.5, but about half of the participants sort of were reaching that interim WHO guideline of 37.5 micrograms per meter cubed. And so because of that, we wanted to understand what types of indicators of chronic disease might be impacted by those exposures. And so one of the, also driven by the community engagement, a lot of families were really interested in diabetes risk. And so we measured a marker of diabetes risk and were able to see associations between our measures of, as women were evaluated over the course of the 3 years, we saw reductions in their PM 2.5 exposures and improvements in their marker of diabetes. And so that was something that we were able to provide to the families and sort of report back these results in the community engagement approach with a stove that perhaps isn't as clean as we would hope for many of the communities. But I always like to point to Omar Macera's work in Central America too, because he talks a lot about just transitions. And so when you're in rural areas in Central America, there is not the infrastructure for electricity, there's not the infrastructure for LPG, and I think there will be building momentum around those types of fuels, but for now, 5 years after our study, we just went back and families are happy with their stoves, and they're doing work right now to understand what families will pay for as far as replacements and maintenance parts for these stoves, and it's really encouraging results, actually. Yeah.
Yeah, that is really encouraging, and I couldn't agree with you more on that. I mean, before I started working with Professor Olopade, my PhD research was in Bolivia, and there was not electricity or roads to where I was when I first started, so LPG and electric cooking were, not on the table for any time soon. And so the best options is make your home environment as clean as you can. It was rural, so we could, ship it out to the ambient air, the ambient. But I agree with you. I think we have to look at this very contextually. And obviously, for the urban areas where people have access, we want to move to as clean as possible. But for other areas, we want to do as much as we can, because I can tell you, if I can go into a house and just have a little bit less air pollution where my eyes aren't bothering me and I'm not, like blowing black stuff out of my nose, that reduction, I feel better. And so over the long period of time, the years of that, reducing those levels, I think can't hurt you by any means. I want to ask one last question, and I'm going to not allow Maggie and Heather to answer it, because I want it to have the men who are going to ministries in their own countries, talking to their ministers. And KP actually is prompting this because he said something that was very poignant the other day about who should be talking to ministries when we're giving messages and how we do that. And so I'd love to hear from each of you and your work, because you work on research that's so important. But at the end of the day, if we don't have policy changes to promote this, to promote clean cooking, to provide supply chains or an enabling environment that supports the scale up, we're not really going to see transitions. And so at the end of the day, we need to have policy involved in this. So KP, from your perspective, you gave the PATH example. Maybe if you could give that again. How do you go about this? And what do you think is the most effective in communicating stuff like this?
Well, thank you very much. Let me just say that we are a government institution, Kintampo Health Research Center. We work with our colleagues from Columbia University and from elsewhere. And so the acceptance of our results to any government agency is high because we answer to the president, you know. So that helps. But before that, we have been able to bring the policy makers and the policy changers on the table right from the beginning of our trials. So we had meetings with the Ministry of Energy and the Ministry of Health. We got them to understand the trials. We've written up a document that catalogs all the results of our studies, including some of the implementation research that we have done. And then also, we've been able to engage them to understand that we always need to measure the programs that they put in, irrespective of what the drive for the program is. And so, I think going forward and getting our results into policy requires people that speak like the ministries of health and the ministries of energy, people that communicate with them, people that resonate with them. And I was given an example of an NGO that is based in the US but has several presence of local people communicating the research where they have been involved in. I'm excited that for most of our discussions on clean air, it has been partnerships with people that have done the research and people that have contributed to it from elsewhere. The problems can only be resolved by people that are actually feeling the problem and experience it. So I think that's how we have to go. Thank you.
Thank you. I must say, about 10 years ago, some colleagues of mine did work within the city and found that actually pollution levels were actually very high, 6.6 times above the WHO recommended levels. At that point, the question was, where do you start? We tried to engage the National Environmental Management Authority, but I mean, the level of interest was not that much. But coming to this meeting somehow and listening to what others are doing, I think it definitely needs a multi-sectoral approach, including people from Ministry of Energy, Ministry of Gender. Women are disproportionately affected by the hazards of air pollution, and Ministry of Health too. And as KP said, something which can be implemented in a programmatic way, and the stakeholders, once they appreciate it, then I think it can be rolled out easily, rather than a top-down approach. Thank you.
Yeah, I live in Chicago, but I'm from Nigeria. I do all of my work in Nigeria. There are challenges and at the same time opportunities. Nigeria, for example, has been subsidizing kerosene for a long time. And the study that we did in Nigeria really showed that kerosene, charcoal, firewood, they're bad. Kerosene is just terrible. But we haven't been, even though we've published and we've had opportunity to share with, I don't think the subsidy to remove subsidy on kerosene to make it less available has been implemented. And another fundamental challenge across probably most of the African countries is that if you're talking about clean cooking and renewable energy, you're talking to people in the ministries of energy and the environment. They're not the health people. So sometimes people are talking across purposes because the people in the Ministry of Health are frustrated and waiting for people from the Department of Ministry of Energy to eventually come to them. And they might not be in the most cooperative mode to listen to them. So those are major challenges, but one has to also just keep going. And I know that shortly after studies were published too. I was very excited. I was close to the last election that Nigeria was going to spend so many $1 billion on distributing stoves. But I don't know what stoves they bought. I don't know who got any stoves. I don't think it's changed anything. I think it was just an opportunity to use that environment, to have access to funds and to, splash that they did something about it. That said and done, though, I mean, the current study that we're doing with the Lagos State government, we have great collaboration. They're excited about the work. I mean, we have more than 50 of their community health workers, their directors. So everybody is really, really engaged. So I think one just has to remain persistent and try and get to the right people. Because whether we like it or not, the government must provide a permissive environment. They must be able to write policies that will guide all of these implementation and mitigation strategies that we're interested in. It's not easy, but that's why we do the work.
Thank you. I mean, right to your last point, because I sense some sense of frustration about kerosene still being used. There are big players in this industry, bigger than the scientists. And so maybe, as I said previously, maybe we are really not the people to be doing this, and maybe we should acknowledge that our science is not just the bullet thing to change anything, and it has to be continuously done by somebody, maybe somebody, an NGO, somebody that is persistently looking at it.
I think that's very true, and we've experienced that in a lot of places. But we will continue to do research because it is important to know and important to provide the data to government. At the very least, I think that's our job. So I want to close this panel and thank all of you, really just a wonderful panel. I think we've come a long way in understanding the health impacts of air pollution and the potential that clean cooking has come. And I still think, 10 years down the road, we'll be here or in another panel and there'll be so much more, which is exciting for me. But yeah, I want to thank each and every one of you. Yes, I'm going to open it up to the audience only because they're asking us to hold people here, I guess. Oh, it's because lunch is starting 30 minutes later. So let's take a couple of questions because we have a couple of minutes and then we can head out to lunch early. Go ahead. Can somebody? Oh, there is somebody.
My name is Faustina and I want to ask the director from Kintampo. I spoke to Dr. Sribo, who is the chief cardiologist at the biggest hospital here in Accra, and I asked him whether he knew about indoor air pollution, and he was like, "What's that?" And when I explained everything to him, he went like, "Oh, that's why we see people's chest black." He thought that was coming from smoke. But he had never, actually thought about it. So I should have suggested, well, I'm not part of the organizing team, but this is somebody who should have spoken to us here at this forum about the kind of things he has seen that he thinks is coming from soot, and black smoke and all that. So I would suggest to you that probably you have a conversation with him since you are all in the medical field. And then probably you can have a little research around that with him. And next time invite them here. GACO will be intensifying sensitization and education on clean indoor air because, you see, the ministry people do not really understand or know. If the chief cardiologist doesn't know about indoor air pollution, I sat on a plane with somebody who worked at WHO and I asked, "Do you know about indoor air pollution?" He says, "What's that?" You see, so the health people themselves never even think about that, never connect cooking, You know, because it's cooking, it's women. It's not anything that anybody would think about, you know. So the big research institutions who are doing a lot of work on clean cooking should involve the health personnel and all that, and to share this research with them, and probably even go to the field with them, so that they can see that a lot of people are so ignorant about. I'm sorry to say that they don't know about indoor air pollution or anything. We need to intensify the education around that. Thank you.
Yeah, you raise a really, really important point about our research, our communications, and I want to let KP answer because it was directed at him, but also I think Heather, because WHO has a really interesting program around this, and so I think we are trying. And so, KP, do you want to start, and then we'll pass it to Heather?
Yes, thank you very much. And the gentleman you mentioned is a top-notch cardiologist and cardiac surgeon. You're right. I mean, I for like 20 years, people have been asking me, what are you doing with household air pollution as a doctor, right? And you struggle to tell them that it has impact on that, and they're like, so what should people do? You know, and we were not taught in medical school to say that if you have a pneumonia, don't use firewood. If you say don't use it, what should the person use? So the times are changing, and the education is absolutely important. We had the opportunity to educate and include household air pollution impacts on health as part of the continuous professional development, but not everybody has attended. But there's a lot to be done, and I think a lot is being done by WHO.
I loved your question, because this is something we have been really working on at WHO, and I'm really, really delighted to say we have been developing basically a training package for health, for clinicians, for community health workers, for nurses, for midwives, for them to understand the risks of air pollution and the interventions that can be done. So we really are driving the health sector to prescribe clean cooking, prescribe clean air to protect your cardiac, respiratory health, all of those different adverse pregnancy outcomes, et cetera. And even this summer, we went to Kumasi. It was a pilot. The pilot study, we had clinicians from all around Ghana come, and they learned about ambient air pollution, an introduction to household air pollution, and we're teaching them to train other doctors and clinicians, and we're hoping to do the same thing with the community health workers moving on. I know there's other important programs that are going around. I know the University of Liverpool is working in Kenya to do training community health workers. So we at WHO, we're trying to promote this and really encourage this, that this is an important place, because you're going to believe your doctor. That's one person you're going to trust. And if they're going to say, look, what are you doing? What are you cooking on? You need this to be cooking on. You need something clean. You're going to trust that, and you're going to see their value in that. So we're really trying to do that and really introduce that. Another thing is the medical curriculum of medical schools. Air pollution's not included in, we haven't actually found one medical curriculum that has air pollution and medical school curriculum in it. So we're trying to advocate at WHO to also get that into the curriculum, because it's an important risk factor across the entire population.
Thank you. I think we will close so we can get up to lunch, but I want to say you're right. Like, we need to communicate better. We need to think about education as we go forward of the doctors, trusted community members, because doctors always are, and if our cardiologist doesn't know about household air pollution, that is a problem. But yeah, the really good question. Thank you so much. And I guess I cannot turn Josh down, just like Alyssa could not turn me down. I cannot turn Josh down. So yes, go for it, Josh.
Thank you for indulging me, Donnie. And this is relevant to the previous discussion, which is why I wanted to ask it. Turning from the specialist to the communities, and picking up on something that KP said Monday in our workshop about lobbying. I'm interested in perspectives from all of you, but particularly from the Africans. What can be the role for community support to drive the lobbying, if you will, the policy? Can they do that effectively? Are there conditions where they need NGOs to advocate for them? Is that something that you see is potentially useful in this regard? And if so, how?
I think the importance of the community engagement of the community is very, very important. And what we're trying to do and encourage people who do research in Africa is to think about a community-engaged participatory research, because when you go into a particular community to do research and you get the community involved at the get-go, they can even give you ideas about what to do, what not to do. That's an opportunity to get it from bottom up. Can we do better with communication? Yes, because I remember about 15, 20 years ago, breast cancer used to be a taboo in Africa. Women had a lot of aggressive breast cancer, but they just covered it up. But there was a particular, at least talking about Nigeria specifically, there was a workshop that brought professional women, the market women, and everybody together and demystified breast cancer. Now everybody is talking about breast cancer. People who previously were not talking about their medical history, they're talking about it. So I think anything is possible, but we just need to identify the community leaders and people that people respect in the community that can speak up on all of these issues. And clearly we have more data than we need to be able to engage stakeholders and opinion leaders to be advocates for this. So I think it's very, very possible, but you know, my friend KP knows the politics, works with the government people more than I do, but you need to really get, because their interests might not be always aligned, but there's a way the community can be empowered to speak up, and if they speak up loud enough, people will listen.
Thank you. I do not have a lot of community experience, but my take about that question is this. Indeed, I think the NGOs do have a very important role, because I think that's when the community really can buy into it. The second thing, as mentioned earlier, was a forum to be able to share this information. I was pleasantly surprised that one of the clean energy products I saw out there was originating from Kampala, Uganda, and had no idea about it. So I think a local forum in which various stakeholders can share their interventions and innovations would be very valuable. And then at that level, you can engage the government to facilitate, because I had a chat with them and they were stuck with other regulatory issues. For example, tax waivers on clean energy sources would be something that the government can do, but I don't think the government can roll it out for you in the communities. Thank you.
Thank you. I think community demand is strong. In fact, in Ghana now, if a community says we need a CHIPS compound is the lowest level of care in a community, politicians shake and they move technocrats and they move implementers, and it goes in that manner. And so that level of engagement is absolutely crucial, and NGOs could do that. The other bit is what CCA has done. You brought one of our finest ladies in the person of the second lady of Ghana to this forum, and it's going to be carried along. I mean, if she goes and says, my husband, can you ensure that LPGs, I mean, it will be done, you know? So that level of engagement and lobbying is also very important. Thanks.
Yeah. All right, I am told we need to close it, and really we could ask questions all day because there's so much to learn here. But again, let's give a hand to our esteemed panelists. Thank you so much for taking your time and for being here today. And I think we have lunch down here and again upstairs that we can head to.